Difficult thing to teach is manual therapy in itself. It can be challenging to teach it because everybody's hands are different, everybody grades things different. And so manual therapy is what I call subjective objective. Just like manual muscle testing is subjective objective. It's objective for individual therapists, right? But different therapists, if we all do manual muscle testing on each other, we all gonna come up with different scores. But it's objective for us with a specific person. Does that make sense? So, but one of the best ways I can explain the different grades, because that is different. I can come by and do them on you and explain them on you better than just verbalizing it. You have to feel it. So when we talk about grade 1 through grade 4, so what are we talking about? So if you come around, I'm going to use my thumb on this plinth, like to kind of give you an illustration of what the different grades look like. So if I come right here, right, you see this plinth, you see the mat. We call this is the resting state. All right. So I'm gonna push down on this mat as far as I can. So this is as much as I could push down. All right. So everybody see this right here? This is as far as I can go. This is to my end. What grade would this be for me? That would be a grade 4. So now I'm gonna back up off of that. That would be the grade 4. So now I'm gonna determine my other grades off of that. Okay, we could do the same thing with our patient. If we want to know our grading of how we're grading their joint modes, we could go ahead and try to get them to a grade 4 to the end. That way you know they're in. Then you could determine your grade 1, 2, 3 off of that. Does that make sense? So right there, that would likely be a grade 1. Does everyone see that? So I'm gonna consider that my 0 to 25%. So that grade 4 was 0 to 100% of the range available. So that was grade 1. Go a little bit further. That's likely grade 2. Does everybody see that? So that would be a grade 2. So I went from 0 to about 50% of the range of motion. That's grade 2. I come back off of that. Now I'm going to try to go grade. That would be grade 3. That's grade 3. So that would be my 0 to 75%. All right, that's grade 3. Remember, grade 3 and grade 2 are large amplitudes. Grade 1 and grade 4 are short amplitudes. So now, and this is when we're talking about oscillations. So I'll make grade 3 right here, right? So now, that's my grade 4. That's as far as I can go. That's the end range. Now, say I want to oscillate between grades 4 and 3, I'm gonna go. You see what I'm doing? So I'm mimicking oscillations between, so basically I'm mobilizing a joint between grade 3 and grade 4. But this amplitude, what kind of amplitude is this? It's a small amplitude. Why is it a small amplitude? I'm not going that far of a distance. So I'm going only about 25% of distance, because what am I doing? I'm going from grade 3 to grade 4 oscillating. All right. But now say I go grade, so say I'm gonna back off and go grade 3. So say I go grade 3 all the way to 0, back to 3, back to 0. So all the way back to 75% and back to 0. That's my oscillation. That's a large oscillation, right? Large amplitude, right? So that would be oscillating grade 3 all the way back to 0, all right? And then grade 2 is a larger amplitude. So say I go 0 to 50%, back to 0 to 50%. That's a large amplitude, right? That's a longer distance, all right? And if I come here and I go right here, right? Say that's grade 1. What kind of amplitude is this? It's a small distance. I'm not going that far. So I'm starting at 0% of the motion, going to 25% of the sensor motion, and I'm oscillating back and forth. So that's a smaller amplitude. So my grade 1 and grade 4 are small amplitudes. I'm oscillating short distances versus grade 2 and grade 3, I'm oscillating larger distances. Now, it's important to know that. Why? Because now we're going to be doing joint mobilization for treatment purposes. Last semester we did it for assessment purposes. You're looking for whether one is more hyper or hypo. Don't forget that. That's very important. All right? Because if the joint is hypermobile, is joint mobilization indicated? No. More likely the person may need some stabilization, strengthening done. All right? That would be your line of treatment. Okay? Now, if the joint is hypomobile, is joint mobile indicated? So in that case, if it's hypomobile, then you likely assess your soft tissues that could be restricting it. If it's soft tissues restricting it, you address those. Then you do your joint molds, then your supporting interventions.
So if you think about when you were assessing the motion, right, last semester, and you had to take it in range, right, in order to determine what grade of restriction or what grade of motion you would give it, right? So how would that correlate to you with that grade 1, 2, 3, 4? What do you think? How far were you taking that?
Depending on how much restriction, depending on what grade you use.
Well, just, so let me clarify. So if you were taking it to assess it, you probably took it to that end of range, right? So which would equate to a grade 4, right? So you kind of know you've gone from 100, or from 0 to 100, right? So you've assessed it, you know where you're at, and so that's going to give you that range that you're now going to decide how you're going to treat it, right? Are you trying to have mechanical effect? Are you trying to have mechanical effect? What grade are you going to use? 3 and 4, right? So now you know that range. So now you know you've got to go at least to that. You can do a large amplitude somewhere in that 75 to 0%, or you can do a smaller amplitude at the end range from 75 to 100, somewhere in there. But that's where you're getting. That's how you're going to know what your available range is, and so you're going to break that up. On one person, you might only do right. That might be 100. You get into 100% is very minimal, right? Somebody else who's maybe a little more hypermobile, you might have to go really far to get to 100%. But that's just trying to connect that there. So you've gone from 0 to 100 just to assess them. Tia.
If you're able to get to that grade 4, but they have a lot of pain, you just do like grade 1, 2, 3, and then am I making sense?
It's an excellent question. So what do you think would be the most appropriate place to start?
I would start at 1, I would start low, and then
Because what kind of effects are you going to get there?
in football.
Okay.
Neurophysiological,
Neurophysiological, which is going to abate pain. So now you do you went all the way to end range and ooh, it hurt. So now you decide, I think I'll start in that grade 1 to 2. Oh, and now when I recheck, how about that? I can get to end range and they're not as painful. Now I can try to use some grade 3 and 4 to try to improve the mechanical effect. So it all works together.
Makes sense.
Good question.
Okay. So according to our objectives, we want to make what we do align with a case. All right. So write this down. A patient presents to physical therapy with forward head posture and rounded shoulders with report of limited bilateral upper extremity, limited overhead mobility. So at the shoulders, if the shoulders are rounded, what is a muscle that we potentially need to address? pectoralis minor and major. So we're gonna start with soft tissue. So for problem one, or you can say impairment one. So we're gonna say decreased shoulder flexion, decreased coronal abduction, decreased horizontal abduction, decreased external rotation. Oh man, that's a whole lot. How in the world is that? Decreased scapular mobility? It could be. So now you got, add these problems. Decreased scapular retraction is a problem. Decreased scapular downward rotation. Now, those are all impairments that could result from pectoralis major and minor muscle tautness. The pectoralis major and minor muscles. What are the muscle actions? Internal rotation. What else? Horizontal adduction, all the opposite. For internal rotation, for secondarily, what else? Shoulder extension. Yeah, so everything in the opposite is what we are trying to improve, okay? Everything opposite of what it does. So if it's taut, it's gonna restrict the antagonistic movements, all right? So now, what I'm gonna do is what they call pectoralis major. So my patient has this problem. She rounded shoulder. I gotta try to get the shoulders unrounded. So now I gotta do some manual therapy, which is gonna be my primary intervention. Then I'm gonna follow that with supporting interventions. So she has limited all of those range of motions we talked about. I'm gonna go in and do pectoralis major and minor muscle play. And so basically what I'm gonna do, I'm gonna bring her shoulder joint complex to about between 90 and 120 degrees, somewhere in that ballpark. So now I actually can put my eyes on her pectoralis major muscle, all right? And so I'm gonna use my thumbs to get up underneath her major, and my thumbs are gonna actually be able to gloss her minor muscle, okay? So I'm coming in like so, all right? Can everybody see this? So I'm coming in like so. Dominique can feel this. I'm gonna have to grade this. And so now my thumbs are actually can gloss her pectoralis minor muscle. So right here, I'm good. I feel like I have a good grasp on her pectoralis major muscle. Does everybody see this? And now I could actually mobilize it and lift it away from the ribs in a superior medial aspect. All right, just play around with that. Now my thumbs, now I could do some muscle play of her minor. You feel that with my thumbs? Mm-hmm. So I'm on her pectoralis minor muscle with my thumbs. And so as I lift the pectoralis major, I can back up off of that and go in here and just gloss the pectoralis minor muscle with my thumb. And I feel it right there, okay? Now, I can back up off of this, do this for a while. I can back up off of that and just relax. And I can come back and do some more reps as well, okay? But the pectoralis major muscle, running and attaching to her humeral head, coming off of her sternum, and that's how I do that. That's pectoralis major and minor muscle play. Okay. Now, what can I do if I wanted to actually focus on the pectoralis minor? I'm gonna use my left thumb. So I'm gonna use my left thumb to contact her cord process, right? I got it right there. You feel my thumb on it? So I got a core process right there. So now that I have a core process, I'm gonna take my right hand, and my right hand is gonna go over her third, fourth, or fifth ribs. Hands are gonna come across right here like so. And so now I'm gonna come across and mobilize her third, fourth, or fifth rib in an inferior medial direction. Does everyone see this? Do you feel that stretch of your pectoralis minor? Most of you all will be able to feel it. And so I'm actually mobilizing her core process, in a sense, stabilizing it and seeing if it maintains in the posterior direction. If the core process moves anteriorly, that lets me know that for examination purposes, that lets you know that her pectoralis minor muscle is taut. Okay, but then I could turn back around and grade my treatment for that. So my treatment for that would just be mobilizing the third, fourth, or fifth rib in an inferior medial direction. Does that make sense? And that's going to elongate the pectoralis minor muscle due to its origin and insertion. Third, fourth, fifth ribs, origin, core process. Does that make sense? So I've done some soft tissue work, right? I would need to do some joint mold work. Okay, so she's overhead restricted. She's restricted with external rotation. She's restricted with horizontal abduction, coronal abduction. What joint mobilization techniques can I do? I could do an anterior glide, right? So in this case, external rotation. So come here. I perform external rotation. With external rotation, her pectoralis her pectoralis major and minor have to be able to lengthen, right? So I'm just gonna leave her right here like this. I don't want to change her position. On last semester, I taught y'all how to do the anterior glide with the patient prone, right? Did I show a supine as well? Okay, so you should have a supine. So why did I place these towel rolls right here? Yep, never ever forget it. This is automatically put her in the loose pack position. If I want to, I could put a little small wedge up under her scapula to help facilitate stabilization like I do in the clinic. And but right now I have her, I'm gonna use my hand, my right hand stabilized. I'm gonna come up right here, and now I'm gonna do an anterior glide. So look how, so right here, grade 1. You feel that? Grade 2, grade 3. That's it. That's grade 4 right there. You feel it? That's as far as I can go. I can make this a treatment and oscillate between grade 3 and 4. You feel that oscillation? So I'm able to demonstrate that, and she's able to feel that, those different grades. So I followed the soft tissue work with joint molds. So say external rotation was one of her limiting motions. So we know she had a tight pectoralis major and minor because she has rounded shoulders, right? We know those are tight. So she has problems with external rotation. So I did an anterior mobilization of the humeral head on the glenoid cavity. All right. So what's another joint mold that I can do for treatment? I do an inferior glide. So I'm gonna come right here. I'm gonna stabilize the scapula with my hand, with my right hand, right? And now I'm gonna impart my inferior glide. You all see this? Watch this. That's grade 1. I'm gonna go back. Grade 1. Grade 1 yields what kind of effects? So this is grade 1. That's grade 2. That's grade 2. I'm gonna go back. I'm going from 0 to grade 2. What kind of amplitude is this? Large. Now I go grade 3. That's grade 3 right there. grade 3. Now if I go grade 3 to grade 2, and I oscillate within grade 3 to grade 2, now I gotta extrapolate, because this is not textbook. That would still be small amplitude, because I'm going 2 to 3 on about 25%. But now, that's 4 right there. That's it. So I go 4 to 3. What kind of amplitude is this? So I'm oscillating between grade 3 and 4. Y'all see that? There's a very small amplitude in it, small distance. But this yields mechanical effects. Anterior glides, inferior glides. What else can we do? You can do posterior glides of the GH joint, because what they lack in flexion, right? So, but you got to justify why you're doing it. So I can come right here, and then I could do my posterior glides like so, with my different grades, incorporating different grades. And if they got increased pain, then you're gonna say, most likely verbalize, I'm doing a grade 1, a grade 2 to your neurophysiological effects. And you're gonna go through and state those neurophysiological effects, right? So now, we're gonna go to supporting interventions. So, Ms. Williams, I've done all the manual I'm gonna do with you today. We're gonna transition to some supporting interventions. We're gonna start with some therapeutic exercise, okay? What are we gonna do? Good job. Let's stand up. So one of the supporting interventions we're gonna do, Ms. Williams, you have tight pectoralis major and minor muscles. So one of the interventions we're gonna do, and this is one I'm gonna have you to do at home as well, is a corner wall stretch, but it's gonna stretch out your pectoralis major and minor muscles. This is one of your supporting interventions. But we're doing it now, but this is gonna be one that we're not gonna do in the clinic, because I want to depend on you to do this one at home, daily, okay? So let's find a corner, let's go over here. When you place one hand right here, like so, your hand placed about shoulder level, other hand placed about shoulder level, and you're just gonna lean in. When you lean in, do a slow count to 15. After you count to 15, then you back up off of it. Do that about 4 times for me. There you go. Good job. Now, that's home. I'm gonna turf that off to home exercises.
Okay.
Most of the time, stretches, I turf off to home exercises. Once you teach a patient how to stretch, most of them can do it themselves. So I typically turf those off to home exercises. All right, what can I do in the clinic now with her? Because I wanna see how the person performs it. I wanna assess it. So what can I have her to do? Oh, scapular retraction. Very good job. So somebody said, hold this noodle here, straight up, come straight up. Now, what do we want to do? The objective for our supporting interventions is to elongate the pectoralis major muscle. So what we can have her to do is some shoulder flexion. So anything that elongates it is a supporting intervention. So strengthening it. Now what I can have her to do, because it has been so tight, it's gonna lack eccentric strength. Most likely it's gonna be weak eccentrically, right? So what I can have her to do, I wanna work on eccentric strengthening of the pectoralis major and minor. I can have her to control this. Take it back slowly as far as you can, control it. And that works on eccentric strengthening of the pectoralis major and minor. And then bring it back up. So this would be a supporting intervention. I'm doing this so that you all know how you should be thinking, okay? Good job, okay? Now, I can also, on this side, everybody heard of come right here. So I can have her to do one external rotation. So she's using this hand to facilitate this arm going to external rotation. She can do that for coronal abduction. Okay. Because remember, the pectoralis major has to be able to elongate. All right. Now she can also use this to facilitate coronal abduction. All right. Then we can progress all this, y'all. We can progress TheraBand. We can progress to dumbbells, whatever the case may be. All right, good job. I'm just throwing a lot out there, y'all. This is all supported intervention. Go ahead and sit up for me. All right, sit up on the edge of the plank for me. Now, bring me the cones, y'all, because the weight may be too heavy to start out. The cones.
I know that everything that we've done is for stretching the pec major, but will we also strengthen the other side to for external rotation?
Yes, that's what we can do. That. Yeah, you could do that. I mean, there's a whole lot we can do, y'all. Come right here. Hold them out in front of you. Pull all the way back. So now, guess what? You gotta think based on what you know. So guess what? She's been rounded for so long, right? Person's been rounded shoulder for so long, been walking like this for so long. What muscles in the back are gonna be weak concentrically? Rhomboids, middle trapezius. Those muscles are gonna be weak, right? These muscles are gonna be weak concentrically, and they're gonna be elongated. So what are we doing with scapular retraction? We are strengthening those concentrically, all right? Because we have to. We're strengthening these eccentrically. She's controlling it back, strengthening those eccentrically and elongating them, all right? So this is giving us what we need, scapular retraction. We gotta do that, okay? So that's a supporting intervention, okay? What else can we do? Lie down on your side, on your left side, because we're treating the right side, right? Look, it's a lot. All right, come right here. I want you to start right here with the weight, and we're gonna do coronal abduction. Pectoralis major have to be able to elongate with this. Control it, nice and slow. All right. So going against gravity. Now, let's say the person, you want to work on some concentric strengthening, and you want to do some concentric strengthening, right? Hold this. I'm talking about concentric strengthening of the pectoralis major muscle. Now I put her right here. I'm gonna do this. 5-pound dumbbells, do some chest presses. So if I want to go, I say, oh man, okay, I've got it elongated now, and then I want to go back. I want to go back to treating her to strengthen her concentrically, but I'm not gonna do this dominantly, but I want to incorporate it, right? Because also, as she's lowering the weight, it's still elongating the muscles, right? It's still elongating the muscle. So this adds concentric, eccentric strengthening as well, all right? Does that make sense? So you have to know what's happening with muscle action. Next technique that you will be taught is the subscapularis release. Now the subscapularis release is an extremely beneficial technique. It can cause the patient some discomfort, so it's a technique that you do have to be cautious with. Most likely, most patients are gonna have some discomfort with this technique, but the payoff is good. That's a good payoff. So it's a good trade-off for the discomfort that they may experience because it's going to increase mobility. Most who have a tight subscapularis muscle, if it's very stoved up, it can mimic adhesive capsulitis. Why is that?
You're gonna have limitation in flexion and external rotation.
Which limitation is going to be greater?
External rotation.
External rotation, right? So it can mimic that capsular pattern of adhesive capsulitis, but you need to go check it because if a patient is coming and they present with a capsular pattern, it could just be due to the subscapularis being a tight muscle. It may not be adhesive capsulitis if they're not experiencing pain within the joint. So then you have to figure out what could it potentially be, and that could be a culprit. So it can mimic adhesive capsulitis, frozen shoulder. Don't forget that. It could be very stoved up, or just a taut muscle. That could be the problem, especially if someone has been in a sling. So say you get someone who maybe had a shoulder injury, or maybe had some type of, say they may have had some type of soft tissue injury, and they was just placed in a sling. Or they could have even had something at the elbow and just placed in a sling. What's gonna happen is they're gonna be in internal rotation, right, for a significant amount of time if they've been in a sling. And by the time they come out of that sling, if they've been in internal rotation at the shoulder for so long, what's gonna happen to the subscapularis muscle? It's most likely gonna be taut and weak. Now, what other muscle can likely be taut and weak that we just did? Pec major and pec minor, right? So you got to go look at those as well. So that's why these techniques are beneficial that you're learning about. All right. Subscapularis muscle. Where is the subscapularis muscle located? Anterior portion of the scapula.
Yeah.
So it literally lies. So say this is my scapula. Say that my palm is my anterior portion, and say that the back of my hand is the posterior portion of the scapula. The subscapularis lies on the scapula, anterior portion of the scapula light so. Then it comes around and hooks around, inserts around the anterior portion of the humerus because it does internal rotation, right? Okay. So now, I have to find the scapula, I have to find the subscapularis and release it. So I'm gonna bring her to about 100 degrees of coronal abduction. And so you said under the armpit, right? Okay. So now, hold this position right here for me. I'm gonna use my second through 4 fingers to try to get in here. I'm gonna go gently in. So about right here, right? Okay. Now, you feel my hand tapping right here?
Right.
So I'm giving some feedback. She feels my hand tapping right here. I want you to push this portion of your arm into my hand that's tapping. Did you feel that?
Mm-hmm.
So what just happened? Her subscapularis popped into my fingers. I feel it. I felt it move. It contracted. And I felt it move into my fingers. This is how you can find the subscapularis muscle. All right? Now I have found the subscapularis muscle. I can get her to relax. Now my hands, right? Now this is a sensitive area. So the reason why I had her to contract into internal rotation, I want the muscle to pop into my fingers. Because remember, this is a sensitive area, and I don't want to be just anywhere on her armpit. I want to be on the subscapularis muscle. So right now, I'm on her subscapularis muscle. All right? And just what I'm going to do, I'm going to grade my inhibited pressure. Anybody ever heard of inhibition? Inhibited pressure?
Mm-hmm.
So you talk about that in neuro, right? What does the inhibited pressure do? So relaxes the muscle, all right? So it relaxes the muscle. So now I'm just applying inhibited pressure. I'm grading it. How does this feel so far? So it's tolerable. So now I'm going in a little bit more. Did you feel that? So I went in a little bit more. I'm trying to line my fingers on the subscapularis muscle, if that makes sense. So picture my hand being the subscapularis muscle. I'm trying to lie my fingers on it like this. And I'm trying to apply pressure like so. So I'm not doing this right here. I'm not doing this. I'm trying to do this. Does that make sense? Everybody see that? Come in. So another way I can do it, I can come right here. Come here like so. I can use my thenar and hypothenar eminences. I'm gonna go with my thenar eminence. Come right here. Now, take this. You feel me tapping you? Push into my hand. Oh yeah. Now I can feel it. You feel? Her subscapularis muscle is on my thenar eminence. Strain, counter strain. It's the principles of a release technique. So I'm gonna go back with my fingers because I can do it easier with my fingers. So I'm gonna come in. All right, press to my hand, make sure I'm on that muscle. I'm on it. Now, with strain, counter strain, while I'm applying the inhibited pressure, I move the extremity into the movement that muscle makes. Now, if I did strain, then what would I move the shoulder joint into? External rotation. So I could keep the inhibited pressure there while moving into more external rotation. Now, the subscapularis muscle, what's the muscle action for that? So it's a primary internal rotator, right? So if we know that it's a primary internal rotator, if it is taut, most likely taut muscles are weak muscles. If it is taut, is it weak eccentrically? Is it weak concentrically? Or is it weak both? It can be both. It can be both. But what I tend to see clinically, and what I address first is the limitation that it is causing. Okay? So primarily, it's gonna restrict the antagonistic muscle action greater than it restricts the agonistic muscle action. So if the subscapularis is taut, is stowed up, is most likely going to affect external rotation greater than it affects internal rotation, movement wise. But I do address both. But just first, I'm going to address it not being able to lengthen, because I need it to be able to lengthen so the person can have full external rotation, and we can work on strengthening external rotation within the full range of motion. Then I will come back and address internal rotation as well. You see? All right. So now I've done the subscapularis release, right? She's been restricted with external rotation. We'll just leave that as the problem for right now. So in this instance, Dominique has difficulty with doing her hair. She can't lift his arm to do her hair. You say, okay, these are muscles that could be the culprit. This is musculoskeletal, right? All right. Now, what joint modes are you gonna do? You're gonna do anterior glide, a GH joint? Okay, we practiced that. All right, good. What else can you do? Some abduction gotta occur. You do inferior glide as well. Okay. Now, what can we do? So she gotta make this motion, right? So I gotta make this tie in. So I've done GH joint modes, right? So now I'm gonna look at the scapula, because we can't ignore the scapula, because the shoulder joint is shoulder joint complex. So I've done my GH joint modes. I'm like, all right, let's do some scapula work. So turn on your left side. Now I'm gonna go and assess and treat the scapulothoracic region. So So what does the scapula have to be able to do for her to get here? Upward rotation. Upward rotation. You see this? My scapula is upward rotation. What else does it have to be able to do? Elevation. So I could come in, see this, Dr. McClure? So Dr. McClure already know I needed this pillow because I'm working with a female. So all males, you're gonna put a pillow as a period. So I'm gonna come right here and you can just relax for now. So I take one hand, I'm gonna take my left hand, and I'm gonna get the inferior angle, inferior border of the scapula. I'm gonna take my right hand and get superior border, superior angle. And what I'm gonna do is just do some upward rotation of the scapula. You see this? This is in your PowerPoints. So this is upward rotation of the scapula. And I can just work that. I can see, I can set a timer for 5 minutes and just sit here and do upward rotation, mobilizations of the scapula. However long I want to do that. Okay, to get the patient to performing upward rotation better. I can also take my hand, take my weld space, come around an inferior angle, inferior border, and just let my hand rest right here and do some cephalic movements. This is what also known as elevation of the scapula. I set a timer, see how long, I may say 4 minutes. I'm just sitting here and work on this for 4 minutes and talk to the patient. All right, that's cephalic mobilization of the scapula. So now, supporting interventions. All right, I want to keep her just like this. I don't want to move her. And I want to implement a supporting intervention. I already got her sideline, and I don't want to move her from sideline. Good, sideline external rotation, give it away. All right, there we go. Coming up like this. Sometimes I take the patient through the motion. Good, that's what I want you to do. Go ahead and do about 3 sets of 10 reps. Good job. Any problems with that? Okay. So that could be a supporting intervention. You see? So now you just have to think through it. All right, what else can she do?
I was thinking though, was that when you punch up, her scapula should rotate outwards.
Okay, so if you've done scapular upward rotation as a technique, yeah, you can justify it with that. Good job, Tia. Also, you can extrapolate. What position is this of the GH joint? Boom. You can extrapolate. I have an external rotation combined doing a press up. You just have to think through the rationality. Now, something else you could do. I don't know if y'all learned this in neuro yet. Go ahead and lie on your back for me. These are my favorites. Don't ever forget about these. Your P&F patterns, right? So I can have her doing, I could do D1 or D2, because she got to go into external rotation. So I'll start with, I'm going to start with D1. D1, she starts right here, internal rotation with the dumbbell. This is D1. Bringing it across the body, bringing it over to the opposite ear. So now ending in external rotation, right? Starting in internal, ending in external rotation, right? That's D1. I can come right here and do D2. Starting right here and coming here like so, right? That's she's ending with the GA joint in external rotation, okay? And coming back down like so. And so don't forget your P&F patterns and the movements and what they do as well. And then if she has pectoralis major, minor tightness, I come right here, start right here with D2 and like so. For pectoralis major, minor lengthening as well. And then come back. But I love my P&F pattern. Don't forget about your P&F. I use P&F a lot in the clinic. D1, D2 patterns at the upper extremity. What else? Chopping patterns too. I utilize those as well, but I'll come back to those. Infraspinatus muscle is one of those muscles, again, that can limit mobility and shoulder joint complex, especially the internal rotation, reach behind your back. So infraspinatus is taut and tight. You're not going to be able to reach behind your back and arch your back like you should be able to do, because that requires internal rotation, right? It's an external rotator. So we have to improve the extensibility of it whenever we want to do any type of internal rotation type of motion. Okay, so now I want to assess her infraspinatus muscle. And I actually want to assess both fibers. We have upper fibers of the infraspinatus muscle, and we have also lower fibers of the infraspinatus muscle. Okay, so what am I going to do? All right, so this is what I'm going to do, right? Bring the face of shoulder, bring up here joint. So about 90 degrees of abduction. All right, I'm gonna start out with her inscaption. Scaption is between abduction and flexion, right? So I'm gonna start her right here, right? Now, I'm gonna take my mobilizing hand and make it my left hand. I'm gonna take my stabilizing hand, because there is a stabilizing hand on with this. So I'm taking my thenar and hypothenar eminences, and I'm gonna come right up underneath here, and I'm gonna try to capture the lateral border of the scapula. All right. So now I feel good. I feel that I have a good contact with my hand near the area of the lateral border of the scapula. Now what I'm going to do with her glenohumeral joint is I'm going to adduct it. All right. Now, right here, you feel your lateral border of the scapula in my thenar and hypothenar eminences. So now her lateral border is coming against, I can feel it, it's coming against my thenar and hypothenar eminences of my right hand. I have to maintain her in horizontal adduction. So I have it to where her infraspinatus is now stretched. Her infraspinatus is now in a stretched position. It is now in an elongated position. Okay. So what do I want to do? If I want to assess the upper fibers, I take her, I maintain that position, and I could use one hand because my hands are big. And I assess her upper fibers by moving her into external rotation and maintaining horizontal adduction. And I feel that I'm maintaining it by keeping my thenar and hypothenar eminence in contact with the lateral border of her scapula. You feel that? I should be able to press down like this. She should be able to feel it. All right. Now you see how much external rotation she has? This means her superior fibers are extensible. Okay, that's a good amount of external rotation. Let's see about her inferior fibers. So with the inferior fibers, to assess the inferior fibers, I'm gonna move her into internal rotation. Now I feel more resistance, but that is typical. I feel more resistance with maintaining horizontal adduction and moving her into internal rotation. Do you feel it? So yeah, so I can do a prolonged static stretch here, and I can grade it as I feel creep. I can move her into more internal rotation if I can, but this right here is now elongating the inferior fibers. So you could think of it like this: internal rotation, forearm going inferior, stretching inferior fibers of the infraspinatus. External rotation, forearm moving in a superior direction, stretching the superior fibers of the infraspinatus. Okay? So now, that's the stretch. But you can also get underneath and you can strum and stroke the infraspinatus
Smaller hands, how would I?
Okay, so here's how I like to
I thought McClure had
Right.
them.
So I like to get in here and I have to use my stomach like my third hand, okay? So I will get in here still hypothenar and thenar, and I will get in here and I will get against that lateral border of the scapula, and then I will wedge my elbow right into my belly, okay? So that I can keep myself stable. And then if I feel like I can control it here, so I'm gonna come across so I feel right there, I feel her border pop into my hand. If I feel like I can control it here, I'll do it here. Sometimes I can't. So can somebody hand me a pillow? If I feel like I can't maintain the arm, like I'm just not strong enough to do it all, then I will get another barrier, like so, okay? And now I can still do what I wanna do, but I have a little bit of help to prop. So just relax, though, don't help me, Ebony. Ebony's helping me right now. There we go. And now I have a little bit of help to support the arm. So that's how I like to do it. Same thing here. Now sometimes I can do it with my hand, sometimes I need help. Sometimes, now Ebony's got decent motion. Sometimes people are so tight that I can get right here and that's all they got, and I can just wedge them right against my arm and do it. So it just all depends on your patient. Does that help?
Yep. And so that's the stretching of it. But you can also get up underneath here and you feel me? So you can make it just strong. You can strum the infraspinatus muscle. Just strumming it like so. Typically, I do strumming techniques of the infraspinatus muscle before I stretch it. So I just get some lubricant on my hand, some free up, put my gloves on, and I just get under here and just strum that infraspinatus muscle.
Put some patients to sleep though.
It does. They get relaxed. And by the time they're relaxed, they're able to move better, you know. Now sometimes it could be painful or cause some discomfort if they just haven't been moving that shoulder. The muscles haven't been moving, and sometimes, you know, according to some literature, they can develop active trigger points, you know, that causes startle responses or just tender spots. So I work on that, desensitize that, decrease the startle response. Next thing you know, patients start to move better. Whenever you apply pressure to a muscle, or you inhibited pressure, you strum it, or you squeeze it, the patient wants to move away from the pain. Or you see a strong grimace on their face, that's what we call a nociceptive startle response. Now, I've done some strumming of the infraspinatus muscle, superior fibers and inferior fibers. So now go ahead and turn on your stomach for me. Lie on your stomach. Let's show you what that would look like. So basically what I was doing, we were on this side, right? So I was using my hands were like this, just strumming the muscle, over down the muscle. So it would look like this if the patient is prone. You see? Just strumming the infraspinatus muscle. And she should feel that. And I know the orientation of the muscle because this muscle is located where? Posterior aspect of the scapula. What other muscles back there acting as an external rotator? Yep, teres minor. Now, we work on the soft tissue mobility of the infraspinatus, all right, and teres minor. We know that they are external rotators, right, of the glenohumeral joint. Now, we worked on the extensibility of those muscles. So those muscles were taught, right? They are weak. So we're gonna say they're weak eccentrically, all right, just to start off. But we know that they could be weak concentrically as well. What are we gonna do? What are our supporting interventions are gonna look like? What can we do prone? That's why we got a prone. Since we got a prone, we gotta think about everything we can do. All your wide W's and T's, and to the right edge. Don't fall off though. Don't fall off. Actually, scoot back just a little bit more. I'm sorry. I wanna focus on elongating. Come right here. Lie down. Go ahead, lie down. Don't be afraid. Come right here. I'm gonna do this right here. All right. So this is gonna be your starting position, right? This starting position, I want you to move the weight like this. Because what is she moving into? Internal rotation, control it, and then come back up to neutral right there. She's controlling, and she's not just letting it flop down, she's controlling it. So that's working on eccentric strength of what? Eccentric strength of the infraspinatus, all right? Because remember, when a muscle stove up and tight, it's likely gonna be weak eccentrically. That's what we wanna tend to address first. Now, this is not cookie cutter, I'm just giving you a starting point. Now, turn onto your side. Can we do this in sideline?
Yes, sir, with the tower right there.
Yep, put a tire right here, so come back. So now, we have to educate our patients to stay in the plane that we want them to stay in, because they will come out of it and do all kind of things. Patients will, believe me. So I want you to stay right here, come up. You can go as much external rotation as you come to, but stay in the transverse plane, and then control it down slowly. Down slow, all right? Now, give me a 5-pound dumbbell. This is too easy for this patient. Give me some heavier over there. That's good. All right, now control it going down. You feel more challenged with controlling it? Mm-hmm. I can have her to go supine. All right, then.
Oh, sorry.
Okay, this is what I'm gonna focus on. Come up. See, I had her position, right? I just had to think as a PT. I said, okay, what am I gonna have her abduct or adduct? But I thought about having her to do something prone as well. So what I'm gonna have her to do is adduct. Take it across and come back neutral right here. So stay in this plane right there for me. All right. Why am I having her to adduct? There you go. Eccentric strengthening. Because her infraspinatus is being elongated as she's horizontally adduct. Okay? And you have gravity acting down as she goes into that, so she has to control that as well. Okay? Good job. So now it's just part of rationality. Could I have done this with her prone? Yeah, I could have done it prone. You know. Now, external rotator, right? So let's do this. I'm gonna do something different. We're gonna go D1 extension. The ending position for D1 flexion is external rotation, right? Now come back across. The starting position for that D1 flexion is shoulder adduction, shoulder extension, shoulder internal rotation, right? So now, if the shoulder's in internal rotation like this, what is position of the infraspinatus? Shorten or lengthen? Lengthen. She's gone from shoulder internal rotation to shoulder external rotation. So if I want to lengthen, either or. Now this is something you have to wrap your heads around the way I'm about to say this. If I want to alternate lengthening the subscapularis and lengthening infraspinatus muscle, I can have her perform D1. D1 starting and ending. So let's go. Just keep doing that. So now, right here, could this be a point that elongates the infraspinatus? Horizontal abduction. See, that's why your P&F patterns are not single plane patterns. They move you in a multiple patterns because they're diagonal. So now you gotta pay attention to that diagonal. At what point in space is the position of the joint within that diagonal? You see? Does that make sense? So I could come back and justify and say, well, infraspinatus is also being elongated with the movement of horizontal adduction combined with the external rotation. You see? Because you got upper fibers and lower fibers. In this case, it would be the upper fibers, right? Combined with external rotation. And at the same time, since she's in external rotation, subscapularis being elongated as well. Joint molds. All right, infraspinatus taut, wet movement is limited. Think first, limitation with internal rotation. Now, what joint mold are you gonna do to help the patient move better in internal rotation? So you're gonna do a posterior glide, right? So as we teach it, I'm telling you how the practical is going. So make sure you use your pillow, your towel roll to put the patient in a loose pack position. Make sure you bulk it up to make sure the patient's in a loose pack position. Like it'd be a little bit bigger than that. Then I come, do posterior joint, posterior mold. Now, the practical can move as fast as you make it move. So if you come in, boom, 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 you get your problem or functional limitations or your mini case, and you come in and say, this is what I'm gonna do. I'm gonna do an infraspinatus stretch of the superior inferior fibers. You knock that out. Then you say what the person, if I give you a functional limitation, you say what the impairment may be. If I give you an impairment, you can say what the functional limitation may be, or this is what can contribute to that, this is what I'm gonna do. You do what you're gonna do, you're gonna say, okay, well, since I did this, since I worked on the infraspinatus and stretched it out to improve the person to be able to do internal rotation, I'm gonna follow that with a posterior glide of the glenohumeral joint because that's also gonna improve internal rotation. You do that, knock it out, explain your grade, and you're able to go through, explain what grade you're doing and for what reason, and you move on. This is my supporting intervention, this is what I'm doing, this is why. And you have a strong command of that, and you're very confident, it's gonna go quick. You're gonna beat the timer. We went over soft tissue for infraspinatus, we went over the stretch for infraspinatus, we went over a joint mold that could follow that, and then we went over some supporting interventions.